Alrighty, hello everyone, and welcome to the latest in public health research. I'm Jen Ahern, Associate Dean for Research, and I'm really pleased to welcome you to our last talk of this semester. It's really been a great series of talks. I hope all of you agree with that, those that have been able to come a bunch this semester. It's been a really interesting and wide range of topics, and I've certainly learned a lot. I hope you have as well. So our speaker today is Professor Mi-Suk Kang Dufour. She's a professor in biostatistics. For our students, you may know her from 142, and hopefully you'll get to see another side of her today with sharing some of her research findings. So she will be speaking about transmission of CMV in a couple of different settings. So just before we get started, a reminder to our students that if it's not in the chat already, yes, I see it there. There's a Google Sheet to sign in for tracking attendance, so please go ahead and sign in there. And I don't know if I have any other announcements. I guess if there's anyone who would be interested in presenting when we resume in the fall, please reach out to me and Lauren. We're starting to put the schedule together already. Got some interest from folks, so get on our list if you'd like to be a presenter in the fall. All right, thank you, Mi-Suk, for talking, and I will hand it over to you.
Okay. So I'm going to talk today about a number of projects that I'm working with a group based in Montreal around the transmission of cytomegalovirus. There's a bunch of different connected projects, and I'm going to focus mainly on two of them, one that's kind of more coming to a close of the analysis phase and one that's starting up. But I thought I'd start with just some background about cytomegalovirus because I think it's a little bit less well known in terms of health problems that we're aware of. And in fact, I didn't know what it was before I started working with this research group. So it's a virus in the herpes family of viruses. It's highly prevalent in adults. About 83% of adults are infected globally, but that prevalence is not distributed evenly across the globe. So in the United States, it's about half in adults by age 40. It's about 1 in 3 of children under the age of by the age of 5. And in sort of North America and Europe, it tends to be less prevalent than in the rest of the world. So there are parts of the world where it's 90 to 100%. It's transmitted through contact with bodily fluids, so semen, vaginal fluid, saliva, urine, feces, breast milk. And it's not as well known because it's pretty much asymptomatic in healthy adults. If you're a healthy adult with a competent immune system, you will likely have no symptoms ever from this infection. It has caused disease in immune suppressed, predominantly around organ transplant patients. So there's a lot of work done around transplant patients and cytomegalovirus suppression. But what is driving the interest in research for me is that it's one of the most common congenital infections. So globally, it affects about 1 in 150 births, but it's the leading cause of neurodevelopmental disability and non-genetic hearing loss. So there are these pretty severe consequences in a proportion of the children who are infected. About 20% of congenitally infected infants will have some sort of sensorineural sequelae, and about 90% of the infected infants are asymptomatic. So it's hard to pick up. It's gone on undetected primarily. And so there's a lot of interest in trying to figure out both issues around prevention, but also around treatment or targeting of screenings. There's a lot of open questions and how to deal with this as a public health issue. So it does have some significant impacts for these babies who are infected. And the costs of those are sort of lifelong disabilities. So it is an important health concern, and we're really looking into ways that we can identify targets for treatment or prevention, either through antivirals or vaccination. So one of the issues with CMV is that it has a very large genome. It's one of the largest sort of genome diversities that we see in viruses that infect humans. It's incredibly variable, but that variability tends to be concentrated in certain portions of the genome, and there's geographic segregation for some regions of the genome, but not for others. So we see differences in strains across the globe, and very highly variable regions that can be reinfected. So infection doesn't confer protection. We see indications in the genetic data that suggest that there's a lot of reinfection throughout the lifetime, and that reinfection results in a more diverse sort of genetic mix of strains of the virus. And some work is being done now to try and find specific genotypes that are linked to particular outcomes, but that work has been fairly inconsistent so far. So we tend to think about this particularly in the pregnancy and prevention realm in terms of primary prevention of the initial infection, and non-primary infection being related to either reactivation or reinfection with a secondary strain, because we know that women can be, or people in general can be reinfected multiple times. And the reason this is important is that we do see in regions, particularly research that's come from regions with lower prevalence, that infection risks associated with that primary infection are high. So transmission risk of about 30% in people who have a primary infection during pregnancy. But we have really very few tools to identify reinfection or reactivity. So it's a bit unknown what the transmission risks are within that group. We know that among seropositives, about 1% of them will go on to have a congenital infection. But because in most of the world, that proportion of pregnant people who present with seropositivity is much higher, so 80 to 90% in much of the world. More of the congenital infections are coming from seropositive individuals than women or people who are negative at the beginning of pregnancy, or who experience primary infections. So right now, the strategies that we have are somewhat limited. There's generally not routine screening during pregnancy in most countries. In some European countries with low prevalence, there is some routine screening for serology in the first trimester, and some treatment is available with valacyclovir that can reduce infection. Among infants, universal screening is uncommon. There is some targeted screening and some screening of symptomatic newborns, or newborns who have symptoms around central nervous system related symptoms or hearing loss. And there is some evidence that treatment with valganciclovir or some other antiviral medications can reduce hearing loss or can be protective for neurologic sequelae. But most newborns with congenital infection are not symptomatic, and there's no recommendations currently around treating non-symptomatically infected, and they're not typically identified. There are a number of vaccine candidates that are under development, and some mathematical modeling strategies have been looked at to see who might be an appropriate target if the goal is to prevent these congenital infections. The models have looked at different strategies, including vaccinating adult women or adolescent girls, or vaccinating young children. And the modeling suggests that targeting young children might be the most effective strategy. But there are still a lot of very open questions about how transmission is really happening, what are the drivers of that transmission, and what might be the appropriate targets for either vaccine or treatment-oriented prevention strategies. So the first study I'm going to talk about is one where we're really looking at transmission within families. And the questions for this cohort are really, does the CMV viral load in breast milk affect acquisition in infants? Because we think that the primary route of infection among infants is through breast milk. And does the timing of that infant infection affect the way that they then shed virus? And then does that viral shedding in the infants have any impact on maternal reinfection? So there's one hypothesis that there's infection that's sort of ping-ponging in the family between the mothers and the infants and potentially the siblings in the household. So we have a cohort that was recruited in Kenya, which is a very high prevalence country. There's about 90% or higher seroprevalence of CMV in adult women of childbearing age. So this cohort was recruited. All of the pregnant people were recruited in the 3rd trimester. They were all planning to breastfeed. If they were HIV positive, they were all on treatment for at least 6 months. And the part that I'm going to focus on, this is a larger study looking at multiple aspects of early development, but there is a cohort of that, a sub-cohort of that study with 73 families who had weekly visits, and every week the mothers, the infants, and any siblings living in the house were tested. We collected samples of breast milk and saliva in the mothers, saliva and urine in the infants, and saliva and urine from the siblings in the same household. We also collected blood samples for infant serology at 6, 12, and 15 months, but I'll focus on the 12-month group because we're really looking at that first year of life. We had one infant that had a confirmed congenital case, and so we're not going to look at that. We've excluded that family from the analysis. But what we're really interested in is if the babies were born without congenital infection, what's driving transmission to the babies? And then is that transmission re-propagating back to the mothers? So we're interested in these transmission from the mother to the baby, transmission from the baby to the mother, transmission from the sibling to the infant, and the infant to the siblings. So the first part of that was really trying to identify when was the timing of infection. And we considered the infants to be infected if we saw a really sustained pattern of viral shedding, and I'll show you what that looks like in just a second, or if we see a positive antibody titer in the serology results. So we're sort of trying to time when did the infection really happen in the infants to see if we can identify these patterns of transmission. So of those 72 infants who were CMV negative at birth, 48 of them became infected over that 12-month period. 7 of them we lost to follow-up. I will say this study was during the period, some of the follow-up was during COVID, and we lost a few of our families to follow-up because of that. And there were 2 with indeterminate results and about 15 negative. So you can see that the transmission was pretty high to the infants within that first year of life. And so this is a sort of model of what we think is happening with the viral shedding. We think that there are some sort of transient infections. This model was largely built on mouse models and observational data with this idea that at some point there's a moment when the infection really takes off and the infants begin to shed at high levels, and then a clearance phase, but somehow there's these sort of transient infections before the infant is sort of systemically infected and has dissemination throughout the body. And so we wanted to see if we see those sorts of patterns in the in the samples that we collected from the infants, and if we could identify when this point of infection where the shedding really began would be. So here's a typical pattern of PCR results. So these are all PCR tested samples. So this is one infant over time. So you see on the x-axis the days since birth, and then what happens in the oral and the urine samples. And so indeed, we do see this sort of transient infections or transient shedding events, and then kind of a time point where there's really a sustained sort of shedding pattern. And so we're considering the moment of infection to be here with the dotted red line, that point where the shedding in both the compartments, the oral and the urine, starts to take off. These little transient shedding events, we're calling them blips, sort of anecdotally. And we're not sure exactly what's going on here, but we think that there's some potential local infection in the mouth for the breastfeeding infants, particularly, and then it's sort of well controlled and it doesn't become systemically disseminated. So there's some interest around what's going on there. Is it the sort of infection starting to take off and then that same infection, or is it sort of repeat small infections, potentially with different strains? If I have time, I'll talk a little bit more about the genetic sequencing data that a colleague of mine is doing for that. But we really wanted to look at what these patterns look like. We see that shedding is much higher in the oral versus the urine samples, which fits with some of the data we've seen in mouse models. And then we wanted to see sort of what is the distribution of that timing of infection. So if we define timing of infection by that moment when the infection really starts to take off in the oral and urine samples, most of those infants were infected within the first 3 months of life. So within that first 90 days. And we did some sort of classification of our timing. There were some infants with a gap in the weekly sample collection. So the colors here indicate how consistent our testing was and how sure we are that we captured the week where the infection really started to take off. And you can see that there's kind of more of a mix of these potentially late identified shedding infants in the later time points. And most of the ones who started shedding within those first 90 days, we had very consistent sampling, as we're fairly confident that that was a well-identified moment of infection. So we were interested in looking at, does this breast milk viral load really correlate with the infection status of the infants? And the first look was just to look at the pattern of shedding. So here what you see in the blue is this is sort of the mean viral load of breast milk samples at those time points among the mothers whose infants were not infected. And we see a little bit higher viral load in the ones whose infants were infected early, so in that first 90-day period of follow-up. And then to do that at a more granular level, what we did was to look at the responses for the 2-week period preceding an infant test by the result of that infant test. So that what you see in blue is for each infant, the 2 weeks prior to a negative test result. And then the red or sort of orangey box is the distribution of viral load in the breast milk samples 2 weeks preceding one of those transient shedding events. And then the green is the infections, so in the 2 weeks preceding infection. So we see this dose response between the breast milk viral load for infants who weren't infected at that time point, and then a little bit higher in the ones who had a transient infection, and higher again in the ones who had an infection that began a really strong shedding pattern. And feel free to stop me if you have a question at any point. I'm sort of going through this fast. So this sort of confirmed the idea for us that breast milk viral load is important, and it is correlated with an earlier infection and the probability of infection overall. And then once the infants were infected, we were interested in whether that timing of infection had an impact on how much they're shedding, sort of the amount of the virus they shed subsequent to infection. So here, the x-axis is the number of days since infection. And on the left, what you see is the oral sample results. And on the right, the urine sample results. And we see that for the infants who were infected in that first 90-day period, their shedding is both sort of higher, and it's a little harder to see in this format, but we also know that the sort of time before they clear the virus is longer, which has implications for the sort of propagation of that infection onwards throughout the family, or potentially to the mothers. So they have a peak viral load that's about a log higher in both of those compartments, so both in the urine and the oral samples. So then we wanted to see if then this maybe impacted reacquisition or reinfection among the mothers. So all of these mothers were shedding in their breast milk at some point. And then we wanted to see if they were shedding in other compartments, so that we had these oral samples weekly again. And we saw transient shedding in about 85% of the mothers. So those kind of little blips of shedding that are either preceded or followed by negative tests. And then we had this onset of sustained shedding that might indicate either a reinfection or a reactivation in about 68% of the mothers. And then all of the mothers who had that sustained shedding had an infected infant. So we didn't see any sort of reinfection, reactivation in the mothers who didn't have an infant that became infected. And only one of the mothers had an onset of shedding before the estimated date of the infant's infection. So the question we were asking is that timing of the infant infection prior to then the mother becoming sort of reactivated or reinfected. And that was the case for all except one. And in that one case, the infant was infected sort of in the early period, and the mother was also infected very close, or began to shed close to that. So it could be that we just are not doing as good of a job of the timing as we would like, or it could be that they were both infected by some other person that we're not capturing in our testing process. So this is similar to what I showed earlier with the infant viral loads. These are the viral loads of the infant oral and urine samples in the week preceding when the mothers began to shed. So the indication that the mother was either reinfected or reactivated. And we don't see as much of a difference with the transient infections, but we do see this pattern of a higher viral load in the infant samples in the weeks that precede a mother's positive sample. So there is this relationship of higher viral load in the infants being associated with the mother having an indication that she has a reinfection or reactivation. So all this sort of taken together to us implies that lowering the viral load might help with transmission. So if we lower the breast milk viral load, we might impact transmission to infants. That if we do have a strategy that's really aimed at preventing infant infection, it would need to be put in place very quickly following birth, given that we're really seeing that the infants are infected very quickly after birth, so within that first 3 months. So any program, if we were, for example, the mathematical modeling results suggest that infecting or vaccinating children is an effective strategy, but all of those modeling studies were looking at vaccination of 1 or 2-year-old children. And if we have this information that really the infection is happening quite early, and that those earlier infections are shedding more, that anything that is put in place would need to happen very quickly. And that if there was something put in place that could delay the infection in infants, either through lowering breast milk viral load or having some protective effect, that they sort of push the transmission to infants outwards, we might reduce shedding in infants because the older infants are less reactive in terms of their viral shedding than the younger infants. And there's some reasons biologically that we think that would make sense. And that it does look like there's this evidence that mothers who are seropositive are being either reinfected or reactivated by infants' infections. There's this passing of the infection back and forth between the mothers and the infants. So the next steps for that, like I said, there's a colleague who's really interested in genetic sequencing to better understand the transmission. So what we've done is use those patterns of transmission within the family to identify samples where it might be interesting to see if they're correlated between the mother and the infant. Is there, because we know that there are these multiple strains circulating in an individual who's been infected more than once, is it that there's one particular strain that's more effective at being transmitted, or is the mother transmitting sort of the whole mix of viruses to the infant, or is there a difference in the strains of virus that are causing transient or sustained infection? So we've used these family patterns. This is a bit of a confusing graph, but this is one entire family and all of the samples we have for that family. And you can see the little red stars identifying points of interest for the genetic sequencing data. So the idea here is that these, the purple line represents the breast milk samples. So there are breast milk samples sort of before and after these, or before and concurrent with this transient event, to see, is this mix in the mother the same as the mix in a transient infection, and then sort of around the time of what we believe to be the time of infection in the infant. So identifying these points of interest and looking to see what's going on with the genetic sequencing or the mix of genetic sequences in those individuals. And there's only been a little bit of pilot exploration of this, but it does look like, at least in this one family, the breast milk population, so the mix of viruses in the breast milk was pretty stable over time. So between week 3 and week 22, the sort of mix of viruses was similar. That there was some change in the variant or the strain earlier in the infant's infection, and later when there's a kind of spike here. So this is, again, pilot work that's being done by somebody who's much more experienced in genetic work than I am, but they're using this cohort data to explore the sort of genetic relatedness of these strains. The other study that I'm more involved with, that's sort of getting off the ground now, is looking at CMV exposures through childcare. So we know that daycare workers have a higher seropositivity and have a higher risk of primary infection. In Quebec, where this study is taking place, most are female and the majority are of childbearing age, so they are at risk of passing an infection on to an infant. And so the questions for that study is really to understand the incidence of both primary and secondary or reinfections among daycare workers. compared to non-daycare workers. And then among those individuals who are seropositive, can we describe what's happening with their CMV viral loads and shedding patterns? How often do they shed? What's the sort of peak? What's their risk of transmitting onward? So in the same way that we see evidence that there's infection going back and forth from mothers to their infants, is there sort of this ping-ponging of infections between daycare workers and young children that they're caring for? And a question for this study is really, who is the appropriate comparison population? So we thought for a long time about who was a good comparison for the daycare workers, who were, at least where this study is taking place, more likely to be born in other countries, which affects potentially what mix of strains of CMV they have on board already, and also the seroprevalence among that population. We see that there is higher seroprevalence in daycare workers. Some of that may be because they're coming from other countries where the seroprevalence is much higher. They tend to be of lower SES, but most in Quebec at least have a post-secondary education. So they are potentially not a good comparison to the general population. So in the end, we're doing two comparison groups for this study. One is plasma donors. So we're using them as an easily accessible sort of general population, but we know that our plasma donor population tends to be a little bit more ethnically homogeneous, more born in Quebec, and more a little bit higher socioeconomic status. So the second group that we're using as a comparison population is hospital workers who have a non-patient contact role. So people who work in the hospitals where we're basing the studies, but who don't have direct patient contact. And at least for our study, they have similar demographics to the daycare workers that we're recruiting. Just logistically, it's an easy population because we have this repeated testing over time. And we know that they have a similar prevalence to the general population. And at least in meta-analyses, it looks like their risk is not elevated. So we're using them as a comparison. So this study is recruiting daycare workers and hospital workers in 3 major population centers, and then about 1,000 plasma donors resident in the same areas. And we'll follow them for 1 year and have monthly self-collected saliva samples from this population. If there are positive saliva samples, they'll be repeated weekly until they're no longer positive. The plasma donor cohort is only being tested at the first and last point. So at the baseline visit, and then again at 12 months with blood samples. But we're interested to see sort of what the shedding looks like in this population, and what the rates of reinfection are in this group that might be at higher risk acquisition of CMV. So that study is just getting off the ground. One of our 3 areas has begun enrollment, and we have about between 50 and 60 people enrolled in the cohort so far. And then I just wanted to briefly mention a couple of other related things. One is a testing method that we're nominally calling CMV scan. So because there is this difficulty of identifying reinfections, there's not currently a good method to do that. There's a group in our collaborators that's really focusing on trying to develop methods to detect these reinfections accurately. And then there's a group who's working with a mouse model to look at whether the relatedness of strains impacts the infection risk. So here, what you see is a mouse model where at the top here is day 0 post-infection. And so all of the mice have been infected with a strain called K181 or with sort of mock infection is the PBS here. And then these strains that are being used are either sort of more similar or less similar to that genetically. And we see at the high doses of reinfection, so the reinfection is all with the K181 strain. And it's been tagged with a fluorescence. So you can see sort of the strength of the infection in the mice when they're still alive. So we put them under this machine at 2, 4, 6, and 14 days to see how much they reacted or how much infection there was with the reinfecting strain. And the take-home message from this is that for those that had no initial infection, we see a pretty strong reaction starting at day 2 and continuing through day 14. At a very low dose of reinfection or primary infection, if you're in this group of the PBS, we see sort of a mild and more localized infection. And then if we look at the K181 column, what that's telling us is that if they're reinfected with the same strain, they have a response at a high dose, but not at a low dose. So the model here is trying to understand the risk of reinfection based on whether the strain is similar to or dissimilar to the initial infecting strain. So this idea of the how we reactivate or how the mice get reinfected at different doses. And so there's some ongoing work with this to try and understand cross-protection. And the reason that this is interesting is to try and understand if there is a vaccine, whether there would be cross-protection across different strains, or would there sort of what would the efficacy be across strains that are more or less related to each other, which could help to determine the vaccination strategy. So I'll stop there. I'll say this is a huge body of work with a lot of really fantastic collaborators based here in Montreal, at the University of Washington, at University of British Columbia. And some of our funding is from Moderna. So just to be open about my disclosures, the Kenya study was funded by NIH. The daycare study is funded by Moderna. And we do receive free test kits from Altona for the PCRs for CMV. So I will stop there and just see if there are any questions.
Great, thank you so much. That was a fantastic talk. I really learned so much. Yeah, please chime in with questions or add questions in the chat.
I'm curious if anyone has ever heard of CMV before. I had never heard of this before I started working on it. Do mothers pass antibodies to their infants in the breast milk? So that's an open question. We don't know whether there is some idea that part of what we're seeing in that transient infection is that the infection is actually controlled by the maternal antibodies. But I don't actually know the answer to that question. There's a lot of open questions. It makes it both challenging and exciting, right? That there are so many questions that we don't know the answers to yet. Yeah, so the idea of this infants passing it back to the mothers is that infection is not protective. So the mother has probably some mix of viral strains, so that we have this evidence that the strain has diversity within a person if they've been infected by multiple strains. So they might be passing it on to the infant, and then the infant is passing it back to the mother. because and so we don't actually know, is it reinfection or is it reactivation of her antibody response and shedding response? So that's another one of the open questions, but we do see this either reactivation or reinfection. And so some of the genetic work is really looking at trying to answer that question of, is it just that the production of antibodies is reactivated by being re-exposed to the same strain? Or is it that she passes a mix of strains to her infant and then a mix of strains comes back and one of those new strains, or so one of the strains is sort of causing a reinfection. In the shedding graph, there was a sharp drop to 0 after a peak. If there's just like kind of one sample down, it could be just that we fell below a limit of detection, or there's always the question of, if you're asking people to collect weekly samples, maybe there was a mistake in the labeling. There's a phenomenal number of samples that were collected for this study. But it could also just be that there's some variability in the shedding patterns depending on sort of how high the viral load was. I know in the breast milk samples, there were some that sort of were hovering around the limit of detection for the test. So we see this kind of jaggedy pattern towards the end of the year. Not necessarily because the viral load is really jumping that much, but because below a certain threshold, the test isn't that great at picking up the virus.
I can ask a question. This was super interesting, and I don't know much about this virus, but and maybe you said this at the beginning and I just didn't retain it, but it seems like the big concern for infants is these possible risks of the congenital transmission related to, is it hearing?
So it could be hearing and central nervous system disorder. So they could have neurologic sequelae.
Are there risks
the biggest one, the most noticeable one is the hearing loss. That's the one that gets picked up the most frequently, because partially because there's screening for that, right? There's infant hearing tests right away in the hospital. So that's the most. There are some infants with with rashes and kind of syndromic things, but it's quite rare. Most of the positive infants that get picked up because of the hearing test.
And do we see health implications for the mothers in this phase of like infection, reinfection, passing it back and forth? Or is this, if the mother's not immunocompromised, then there would be no way to know?
As far as we know, there's no health consequences for the mother unless she becomes immune compromised. It's really just the impact on the infants that's driving the importance of dealing with this infection.
Great.
Yeah, so I think so there's a question in the chat about if prevention is the ultimate goal, would a universal vaccine be offered to all infants at birth, or would there some kind of screening? And I think that's an open question, right? I think it would depend. It depends a lot on what the efficacy is of the vaccine, because we know that there's not a lot of protection necessarily from seroconversion, right? So you can get reinfected, but maybe if it has an impact on how much shedding you have, it would have some impact, like at a population level, of reducing transmission overall. And like I said, the timing is going to be really important for the infant intervention, right? So I think there's a lot of open questions about what would be the most effective prevention strategy. And there's some complexity around if you're asking what population you're asking to take a vaccine. and what the benefit is for them versus sort of the population benefit. Right, because a lot of the strategies that the modelers have looked at are vaccinating children, but beyond the point when it's maybe beneficial for them, more to prevent transmission back to childbearing women. But if it's not beneficial for the infants, it's harder to argue for a universal vaccination program for a vaccine that doesn't actually benefit the targets of the people getting vaccinated. Right? If it's just to prevent the onward transmission, it's harder to argue to put that in place. But if it was really in that very early period of time, there could be potentially benefits. We just don't know. We don't know enough. There hasn't been enough universal detection of congenital infection. It's mostly picked up retrospectively because of sort of testing symptomatic infants. So we don't know necessarily what the benefit would be if we were to screen universally, if there could be a benefit to the infants of an early intervention.
Thank you very much. Was any more questions? Yeah, it's really, really interesting. And thank you so much. We really appreciate your time today. And thanks everybody for joining. And I'm sure you could reach out to Mi-Suk if you have more questions after the talk. So thanks everybody and have a good rest of the day, a good rest of the semester. Take care.
Everyone.
Bye-bye.